Good morning, everyone. Welcome to today's presentation. Salt, your blood pressure and a healthier heart. Simple steps that really work. Today, we'll take an in-depth look into the evidence and what the 2025 guideline says and what it matters for you. My name is Dr. Fernandez from Cardiology 305. Let's begin. Why salt matters for your heart? Most Americans eat about 3,400 milligrams of sodium every single day. That's more than 1.5 teaspoons of salt. The relationship between sodium and blood pressure is one of the most studied topics in heart health. Randomized controlled trials and meta-analysis show a direct linear link. The more sodium you cut, the more your blood pressure drops. Key fact: low sodium diet between 1,500 and 2,300 milligrams per day versus high sodium diet over 4,500 milligrams safely lower blood pressure in everyone. The clear dose-response relationship. Here is the precise scientific relationship. Every 50 millimoles reduction in 24-hour urine sodium, which is about 1150 milligrams of sodium, is linked to a systolic blood pressure drop of 1.1 millimeters of mercury and a diastolic drop of 0.33 millimeters of mercury. Expressed simply, cutting 1,000 milligrams of sodium per day lowers systolic blood pressure by about 3 millimeters of mercury. These findings come from large meta-analysis of randomized trials, which are the gold standards of evidence. How much blood pressure drop can you expect? In people with normal blood pressure, a low sodium diet lowers blood pressure by about 3 over 2 millimeters of mercury. In people with high blood pressure, the drop is bigger, about 7 over 3 millimeters of mercury. These numbers are confirmed in the 2025 American College of Cardiology and American Heart Association guideline. The reduction are safe and happens without any extra medication, just by changing what you eat. Duration matters. Don't judge too soon. Studies shorter than 15 days underestimate the true benefit by about half. Longer studies lasting 4 weeks or more show roughly double the effect of 2.113 millimeters of mercury systolic pressure for 50 millimoles of sodium reduction compared to only 1.05 in short study. Why does this happen? Your body needs time to adjust fluid balance and blood vessel function. Take the long view. Consistent changes over weeks gives the best result. Strong proof from the Gupta crossover trial. JAMA 2023. One of the strongest individual studies in the Gupta crossover trial, published in JAMA in 2023. In this well-designed study, people switch between high sodium and low sodium diets. The result was an average 8 millimeters of mercury difference in systolic blood pressure with a 95% confidence interval of 4 to 11. This individual level data showing the effect is real and measurable in real people, not just group average. Salt sensitivity. Why some people react more? Not everyone's blood pressure rises the same way with salt. This is called salt sensitivity. About 50% of people with hypertension and 25% of people without hypertension are salt sensitive. The American Heart Association scientific statement confirms this. Understanding your own salt sensitivity helps tailor the right sodium target for you. Who is more salt sensitive? Subgroup data. Some groups show a greater blood pressure response to sodium changes. Black individuals had a systolic drop of 6.64 millimeters of mercury compared to 5.70 in white individuals. Asian populations with hypertension saw a 7.75 millimeter drop. Older adults, people with chronic kidney disease, diabetes, obesity, or metabolic syndrome are also more salt sensitive. Because of this, the American Heart Association recommends a stricter target of under 1,500 milligrams per day for these groups. since they benefit the most. Official 2025 AHA-ACC guidelines target made clear. The 2025 guidelines are very clear. For the general population, keep sodium below 2300 milligrams per day. For people with hypertension or high heart risk, the optimal target is under 1500 milligrams per day. These targets are based on decades of solid evidence and are considered safe for most people. The DASH diet synergy, better together. Lowering sodium works even better when combined with the DASH eating pattern, which is rich in fruits, vegetables, whole grains, and low fat dairy. The fat is additive, greater than either change alone. In the DASH 4D trial, for people with type 2 diabetes, the DASH diet plus 1500 milligrams of sodium lower systolic blood pressure by an extra 4.6 millimeters of mercury, with a confidence interval 2 to 7.2. Salt hurts your arteries beyond just raising the blood pressure. High sodium hurts your arteries in ways that go beyond just raising blood pressure. It promotes atherosclerosis, or plaque building, through direct effects on blood vessels. It stimulates endothelial cells to produce more adhesion molecules such as BCAM and E-selectin, and increase production of the chemoattractant MCP1. This makes white blood cells stick to artery walls, the first step in plaque formation. These are direct cellular mechanisms that damage vessel function. More mechanism, inflammation and stiffness. Even a small rise in serum sodium of just 5 millimoles per liter from mild dehydration accelerated plaque formation in the aortic root and thickening coronary artery walls in animal studies. High salt also causes oxidative stress, reduce nitric oxide, which is the relaxer of blood vessel, and increases artery stiffness. All of these effects happen independently of blood pressure changes. Cochin and colleagues in the New England Journal of Medicine call this direct target organ damage to the vessel, heart, and kidneys. Real world risk, umbrella review of all the data. Looking at all the evidence together in a 2025 umbrella review, high salt intake increases overall cardiovascular disease risk by 13%, hypertension odds by 33%, stroke odds by 34%, and stroke death odd by 40%. Every extra 1000 milligrams of sodium per day raises systolic blood pressure by 0.6 millimeters of mercury, increases cardiovascular disease risk by 4%, and increases stroke risk by 6%. Key study, Ma et al., New England Journal of Medicine. A key study by Ma and colleagues in the New England Journal of Medicine used multiple, accurate 24-hour urine collection in 10,709 healthy people. Every extra 1,000 milligrams of sodium per day was associated with an 18% higher cardiovascular risk. Every extra 1,000 milligrams of potassium per day was associated with an 18% lower cardiovascular risk. The sodium to potassium ratio turned out to be even stronger than either nutrient alone. The J-curve myth, why low salt isn't risky. Some observational studies suggest a J-shaped curve with increased risk of both very high and very low sodium levels, but those studies had important problems. They used inaccurate spot urine tests, including sick patients, causing reverse causality, and had confounding factors that were not well controlled. When researchers used accurate multiple 24-hour urine collection in healthy people, the relationship was perfectly linear, with no increased risk at the recommended 1500 to 2300 milligrams level. The 2025 AHA-ACC guidelines confirm this range is safe and effective for preventive coronary artery disease. Sodium restriction in heart failure, the Nuanced story. Unlike hypertension and coronary disease, the evidence for a strict low salt diet in heart failure is more nuanced and less clear for hard outcomes like death and hospital stay. The 2022 AHA-ACC HFSA guideline says that avoiding excessive sodium is reasonable to reduce congestive symptoms. This is a class 2A recommendation with level C evidence. No strict target is set. The focus should be on how you feel. The sodium heart failure trial, largest study in heart failure. The largest study in sodium heart failure trial included 806 patients with chronic heart failure in New York Heart Association class 2 or 3. They were randomized to dietitian-guided sodium restriction. The result was no reduction in death or hospitalization. However, moderate restriction did improve quality of life and NYHA functional class. Subgroup analysis showed no difference by ejection fraction, included in heart failure with preserved ejection fraction. The symptoms improvement still makes it a reasonable goal. 2023 meta-analysis of 17 heart failure trials. A 2023 meta-analysis that combined 17 randomized trials found that sodium restriction did not reduce all-cause death, hospitalization, or the combined outcome of death and hospitalization. An important observation was that moderate restriction between 2,000 and 3,000 milligrams per day appearing numerically safer than very aggressive restriction. In some studies of heart failure with preserved ejection fraction, aggressive limits increased thirst and reduced calorie intake. Salt substitute, a game changer for many. Potassium-enriched salt substitutes, which contain 75% sodium chloride and 25% potassium chloride, are an easy and effective option for many people. The SSASS trial with 20,995 adults in China show a systolic blood pressure drop of 3.3 millimeters of mercury, a stroke reduction by 14%, major cardiovascular event reduced by 13%, and all-cause death reduced by 12%, with no increase in serious hyperkalemia. This is a very practical and accessible strategy. More strong evidence in salt substitute. The 2022 Cochrane review showed that low sodium substitute lowers systolic blood pressure by 4.76 millimeters of mercury and diastolic blood pressure by 2.43 millimeters of mercury. They also slightly reduce non-fatal stroke, non-fatal heart attacks, and cardiovascular death. A 2024 meta-analysis confirmed that salt substitute reduced both all-cause and cardiovascular mortality. Blood potassium rise only a tiny amount of 0.112 millimoles per liter in the study population. Safety first. Who should avoid salt substitute? Salt substitutes are safe for most people with hypertension who have no kidney issues or take special medications. However, they are contraindicated if you have advanced chronic kidney disease in stage G4, G5, a history of hyperkalemia, or if you are taking potassium-sparing diuretic such as spironolactone, eplerenone, or amiloride. ACE inhibitors, ARBs, or direct renin inhibitors. In heart failure plus CKD, dietary potassium should be kept under 2.4 grams per day. Always check with your doctor before using them. Where does all that sodium come from in the USA? Over 70% of the sodium we eat comes from processed foods, restaurant meals, and packaged items, not from the salt shaker at home. The top 10 food categories account for 44% of total sodium. Bread and rolls, cold cuts, pizza, poultry, soups, sandwich, cheese, pasta dishes, meat dishes, and savory snacks. This is why individual willpower alone is not enough. Policy changes like the successful UK reformulation program help everyone reduce sodium intake. The sodium to potassium ratio, often more important. The ratio of sodium to potassium is often more important than sodium alone. The highest versus lowest quartile of the sodium to potassium ratio was associated with 62% higher cardiovascular event risk. Increasing potassium through fruits and vegetables, not pills, is key. The 2025 guidelines and the Dutch pattern strongly emphasize this balance for the biggest heart protection. Calcium and magnesium ratio play a small role, but the sodium to potassium ratio is the star. Practical everyday tips to cut sodium. Here are practical everyday tips you can start using right away. Read nutrition labels and choose foods with 5% or less of the daily value of sodium per serving. Pick fresh or frozen foods over canned or processed. Rinse canned beans and vegetables. This can cut sodium by up to 40%. Flavor your food with herbs, spice, garlic, lemon, onions, or vinegar instead of salt. Cook more meals at home and ask for no salt added options when eating out. Include your family or caregivers. It's much easier together. Your taste buds will adapt in 2 to 4 weeks and food will taste great again. Dash diet made simple plus potassium rich foods. The Dash diet is simple and effective. Fill half your plate with fruit and vegetables. Choose whole grains, low fat dairy, and lean proteins, and limit sweets and ultra processed foods. Top potassium rich foods includes banana, sweet potatoes, spinach, beans, yogurt, oranges, and avocados. The American Diabetes Association recommends focus it on whole foods that are affordable and enjoyable. Summary table, condition specific sodium targeting. Let's review the summary table together. For high blood pressure, the goal is under 2300 milligrams per day, with an optimal target under 1500 milligrams for higher risk people, delivering a strong 7 over 3 millimeters blood pressure drop. For coronary artery disease, the same targets provide 13% lower cardiovascular risk with a linear relationship and no J curve when measured accurately. For heart failure, the advice is to avoid excessive salt over 5 grams per day to improve symptoms and quality of life. The evidence level is C, so the approach should be individualized and moderate restriction is often best. For teaching purpose only, this presentation is intended solely for educational and teaching purpose. It summarizes scientific evidence and clinical guidelines to help explain the relationship between dietary sodium, blood pressure, and cardiovascular health. It is not intended as personalized medical advice. Always consult your own doctor or healthcare provider for recommendations specific to your health condition, medications, and needs. Key take-home messages. Here are the most important take-home messages. Sodium reduction is proven cornerstone for preventing and managing high blood pressure and coronary disease. The optimal target for most at-risk people is under 15 milligrams per day, best combined with the DASH diet and more potassium-rich foods. In heart failure, focus on avoiding excess salt for symptom relief rather than ultra-strict limits. Potassium salt substitutes work well and are safe for most people, but always check with your doctor. Over 70% of sodium is hidden in processed food, so small label reading habits can make a huge difference. Small, consistent changes really do protect your heart for years to come. Thank you for your attention today. I hope this presentation has given you a clear, practical, and evidence-based information you can use. Please feel free to ask any questions. Talk to your doctor or registered dietitian for advice tailored specifically to you or your patients. You have the power to protect your heart, one lower sodium meal at a time. Cardiology 305 is here to support evidence-based heart health make clear. Finally, here's the list of references used throughout this presentation. All studies and guidelines are numbered for easy reference and further reading. These include major trials, meta-analysis, and the 2025 guidelines. Thank you again for your